behalf of my investigators the results of the primary data from our phase 3 determination trial, in which we sought to evaluate the impact of lenalidomide, bortezomib, and dexamethasone, which we call RVD, with either early transplant or delayed or deferred transplant, and very importantly, lenalidomide maintenance until progression for newly diagnosed myeloma patients aged 65 years and younger. I especially want to acknowledge my co-investigators across 56 centres in the United States, as well as the support of the Clinical Trials Network, and in particular also the support of the Alliance. The background to the determination study is summarised as follows. Does the addition of high-dose melphalan plus a stem cell transplant improve outcomes for patients with newly diagnosed disease receiving novel triplet induction therapy combining lenalidomide, an immunomodulatory drug, bortezomib, a proteasome inhibitor, and of course our backbone of dexamethasone integrated into this triplet? And most importantly, does lenalidomide maintenance, which is an oral therapy given until disease progression, improve outcome? And we recognise that high-dose melphalan with autologous stem cell transplant is indeed the standard of care for newly diagnosed patients. And what we found is that the triplet induction regimens, including RVD, are not only highly efficacious with deep rates of deep response and prolonged clinical benefit, but when combined with long-term maintenance therapy with lenalidomide, we have evidence that this prolongs disease control and, in fact, in the transplant setting, improves survival. So given this, the question that we were asking is how much does autologous stem cell transplant enhance the efficacy in newly diagnosed transplant-eligible patients, and can its use be tailored? Can it be delayed or kept in reserve for selected patients? So this is the study design and patient disposition. We gave it the acronym determination. It's a little bit loose, so I apologize for that, but nonetheless I think you can see what we're driving at. And at the same time, we gave initial treatment with RVD for 1 cycle. We actually enrolled into the study and treated 729 patients. 722 patients were randomized. Stratification was by ISS disease stage, which was our classical staging system at that time, approximately 12 years ago. And cytogenetic risk was equally important in our assessment of stratification. Each cycle of the triplet is based upon lenalidomide maintenance, 25 milligrams of lenalidomide administered 2 weeks on, with bortezomib given in the classical fashion, and dexamethasone partnered with our bortezomib. Now, Arm A was our RVD alone arm. 357 patients were randomized to this, and we gave basically here up to 8 cycles of RVD all told. But before we collected stem cells, we gave 3 cycles of RVD, and then proceeded to a total of 8 cycles, followed then by lenalidomide maintenance. Arm B did exactly the same thing, but critically integrated high-dose melphalan, 200 milligrams per meter squared, with autologous stem cell support, and a total of 5 cycles of RVD. And as mentioned, this induction and plus or minus transplant consolidation treatment lasted about 6 months, and then we proceeded to lenalidomide maintenance until disease progression. Now, we started lenalidomide maintenance at 10 milligrams daily for the first 3 months, and if tolerance was confirmed, we increased it to 15 milligrams per day. Our primary endpoint was progression-free survival, and our key secondary endpoints were overall survival, duration of response, time to response, quality of life, and safety. So what are our key findings? Well, for efficacy, what we were able to demonstrate was that there was a highly significant improvement in progression-free survival with the use of early autologous stem cell transplant. And what we saw here was that the estimated proportion of patients disease-free after 5 years was almost 56% for those receiving transplant versus approximately 42% for RVD alone. What's important to understand is that in terms of actual duration of median progression-free survival, it was therefore approximately 67 months for transplant and approximately 46 months for the non-transplant or delayed transplant arm. What was very interesting, however, was that the overall survival was exactly the same, at 81% for the RVD plus autologous transplant, and for the RVD alone with transplant kept in reserve, with median follow-up now in excess of 6.5 years, we saw 80% approximately in the same for the RVD alone. So with follow-up approaching a median of 76 months, we have real maturity in this data. And what was also very interesting to us was that at the delayed transplant arm, actually 28% of the patients received this, with other patients being treated with next-generation novel agents, and most importantly, novel monoclonal antibodies. What was also interesting was similar response rates between the arms, but what's very important to note is the addition of high-dose melphalan and autologous stem cell support did dramatically improve duration of response. Now, what was also interesting was our Mrd negative rates. This is a very important marker for us pathobiologically and has, we believe, prognostic importance. Essentially, here we were able to show that with transplant, we achieved MRD negativity in approximately 54%, and for those patients receiving RVD alone with transplant deferred, it was approximately 40%. And what was particularly important for our patients is that if you achieved MRD negative status, you did just as well, regardless of what treatment you got. Now, what about tolerability and side effects of treatment? Well, in this regard, we were able to show that, much as expected, there were significant treatment-related side effects with the use of transplant, including mucositis, fatigue, and infections. And of course, this was statistically significantly greater in the transplant early group versus those who would delay transplant. We also comprehensively evaluated quality of life. We had excellent compliance in our patients, and what we were able to show is there was a significant drop in quality of life across the transplant procedure, and this was by a drop of more than 10 points, which on a QOL score is considered highly meaningful. The good news, though, is that this was recoverable rapidly and was followed by improvements from baseline throughout maintenance. Now, what was also critical to us is there is evidence both from melphalan and indeed lenalidomide that there is an incidence of secondary cancers. So this was a key toxicity outcome that we monitored carefully. We were able to show that there was no overall difference in the rate of secondary cancers between the arms. However, we did see a higher incidence of acute myeloid leukemia and myelodysplastic syndrome with the use of a transplant, and this is summarized in the data shown to the right. So the implications, our findings confirm progression-free survival benefit to patients using transplant in their first line of therapy for myeloma, and confirms autologous stem cell transplant as a standard of care in the setting of triplet therapy. We also demonstrate the clinical benefit clearly of lenalidomide maintenance until progression. We had a partner trial with our colleagues in France, the IFM, and in their study, which was identical to ours but had only 1 year of lenalidomide maintenance, we improved outcome in both arms highly significantly. Thus, we were able to say that the use of lenalidomide maintenance therapy until progression is now a standard of care. Our results clearly, however, provide support for personalized treatment approaches. And what I mean by that is, if we do not see benefit in overall survival, and you can reasonably delay transplant and use it in a tailored fashion, you can have an equally efficacious outcome in terms of overall survival. So this gives patients that option. And it reflects also the efficacious use of novel therapies at relapse. And I think very importantly, we have real prospective, multi-center national data on comparative toxicity. And I think that's very important in informing our patients and providers and providing our patients with choice as they move forward with their treatment plans. Furthermore, it's very important to frame where we are now. We designed this study in 2009, we started it in 2010, we have mature data in 2022. The really good news is that our triplet therapies have now been added to by what we call quadruplets, with the integration of monoclonal antibodies and next generation novel therapies. And these results from these studies are extremely exciting and promising, and we've heard some of that data at this meeting. And by virtue of that, this I think therefore informs our decision making even more, with the value of certain research tools such as MRD providing us with additional guidance as to what best choices there may be for patients. And I want to thank you very much for your attention.